the thing is that not everything is ideal to be linked to an antibody. Some chemotherapies have the right potency to be linked to antibodies and work better as payloads.
Welcome to Healthcare Unfiltered. It's your host, Shadi Nabhan. We are in the sixth season, year number 6 of Healthcare Unfiltered. And folks, I appreciate your support. I appreciate you tuning in every Tuesday morning. Thank you for being part of the Healthcare Unfiltered gang. Speaking of being Healthcare Unfiltered gang, if you want t-shirts, mugs, anything with Healthcare Unfiltered logo, just hit me up on Twitter, on Instagram, by email at shadinabhan00@outlook.com or cnabhan1968 Today's podcast is with Dr. Paolo Tarantino, who is at the Dana-Farber Cancer Institute. I've invited Paolo to discuss ADCs, antibody-drug conjugates. This is really interesting because, again, ADCs are gaining so much popularity in the treatment of cancers, various cancers. And when you think about ADCs, you're going to find out they're almost what, quote unquote, super chemotherapies, because you're really directly delivering chemotherapy to the area of the cancer or that has a target. But with the expansion of how many ADCs are out there in the cancer world, I've asked Paolo to simplify this for us. What are ADCs? When did they develop? What do we do with them? What are the side effects that we should watch for? I think all of this is important. There's so much happening in ADCs, and no one like Dr. Paolo Tarantino is going to be able to explain these things to us. So I'm very grateful and very happy to have had Paolo join me on Healthcare Unfiltered. And I can't wait for you to let me know what you think about this podcast episode. So let your friends and colleagues know about it, share it with others, and check out my website, shadinabhan.com, and my 2 books, Toxic Exposure and The Cancer Journey. And stay tuned for 2 more books coming out in 2026, one of them on AI and cancer, and the other one is a medical thriller fiction. Without further ado, Dr. Paolo Tarantino on Healthcare Unfiltered. Well, he's here. We finally did it. We finally were able to get the amazing Dr. Paolo Tarantino on Healthcare Unfiltered. Paolo, welcome to the show.
That is such an honor to be here on this show. Long overdue.
So, my command of the Italian language is as good as ciao and arrivederci. So, we have to learn like few more words today by the time we end the podcast. We're not going to let you off the hook.
Pastas. We can try pasta, lasagna, etc.
So let's hear a little bit about you. I mean, just a bit about you, where you practice, what you do, and what brought you to the US.
So I would say it's ADCs that brought me to the US somehow. I'm originally Italian. I was born and I trained in medicine in Naples under the Vesuvius, and then I moved to northern Italy, which is basically the antagonist of southern Italy. There is always this tension in between the south and the north, but I knew that there was this center, the European Institute of Oncology in Milan, that was funded by Umberto Veronesi. There is the guy that basically developed the first adjuvant treatment for breast cancer. I was fascinated by that, and I got to train in medical oncology in a phase 1 unit, which was quite unique because, usually when you train in medical oncology, you're supposed to start from the start of care in each disease, but actually I reverted it. I started from the novel drug, from the latest drug, phase 1 trials, and that's what really put ADCs on my radar very early, because as soon as I started medical oncology training, I was assigned to a few phase 1 trials to follow and to, track the patients, put all of their data. In Italy, you gotta do 5 jobs in one when you're in medical oncology. And one of these trials was with this new drug called DS8201A, which now is known as TDXT or trastuzumab deruxtecan. And I remember at the time when we had the SIV, nobody was expecting too much from this drug just because Daiichi, the company that developed it, was never an oncology company. They didn't do so much oncology stuff, but actually the first patients that we treated with the drug had tremendous responses. And most of these patients had breast cancer, but then we started seeing responses also in other diseases. And that really intrigued me, especially when we started seeing responses outside of the canonical.
So why was there fewer expectations on TDXT? Why were people not really, just because Daiichi Sankyo at the time were not really involved in oncology?
Yeah, that was one aspect shift, but also because ADCs are super sexy and interesting now, but at the time, it's not that we had so many highly effective ADC. For solid tumors, we only had TDM1. That's what we had, which provided 6 to 7 months PFS in 15% of patients that have HER2 positive breast cancer. So most of our patients never saw an ADC in the treatment journey. And let's not talk about other diseases, lung cancer, colorectal cancer, etc. No ADCs. And so it really was not as interesting, and we were not expecting that much activity. But of course, I think that time, 2018, was the beginning of this, on what we're seeing now, the explosion of ADCs. And I was very lucky to be in that field in that moment doing phase 1 trials. And that's the moment where we started thinking about brainstorming. And the moment was actually when we started seeing responses with TDXT in this new subtype of breast cancer, HER2 low, which didn't exist at the time. Nobody knew what HER2 low breast cancer was. And suddenly everybody was talking about HER2 low because we saw responses with this HER2 ADC where there shouldn't have been responses without the HER2 amplification. And so we did this JCO article, putting together minds from everywhere in the world, including Dana-Farber. We reached out to Sarah Toleni, and she was super kind and gave a lot of ideas. And that was kind of the first scientific bridge that allowed me to then knock at the Dana-Farber door and ask, what if I came there and started studying ADCs there in Boston at Dana-Farber? And that was 2021 when I moved to Dana-Farber to do a research fellowship, which in time transformed into a clinical fellowship. And I'm currently now still 4 years and a half later at Dana-Farber.
Are you planning on staying here long term, or is this like too premature to decide?
I would say that's the plan. I do miss my meatballs from my grandma in Napoli. But in general, I found such an incredible environment at Dana-Farber and in the US in general that I feel I cannot leave it too early. The plan is to stay a bit longer.
Yeah. Well, you've got the North End in Boston. I lived in Boston for several years before I moved to Chicago. And so it's really one of my absolutely favorite cities in the world.
It's a great place if you have a good coat.
Yeah, exactly. So I've asked you, I mean, obviously you're an expert in ADCs and so on. Try to simplify it for us a little bit for folks who are not really either basic scientist research or breast cancer specialists or even researchers. What are ADCs?
So let's start from what their structure. The structure is simple. It's just a monoclonal antibody like trastuzumab, like cetuximab, like any monoclonal antibody we use in oncology with some chemotherapy linked to it through a molecular bridge. So you can think of it as kind of a smart bomb. And the idea for ADCs actually comes from a century ago. There was this Nobel laureate Paul Ehrlich, which suggested, that we could treat diseases with magic bullets, something that could selectively kill the disease cells and spare healthy cells. The truth is that we're not yet there, just because ADCs are still in their infancy. We're still figuring out how to spare healthy cells, how to avoid side effects. But what ADCs did is improve chemotherapy, make chemotherapy more effective. And chemotherapy alone can be very effective. It's possibly the most effective treatment we have to cure cancer today. Anthracyclines, taxanes, etc. But ADCs really made it better. And the way they did make it better is through different mechanisms of actions. So first of all, when you link a chemotherapy to a monoclonal antibody, the chemotherapy kind of goes where the monoclonal antibody goes. And so if it's a anti-HER2 monoclonal antibody like trastuzumab, it reaches the cell that overexpresses HER2 and delivers the chemotherapy in the tumor cell. But that's just one of the layers of how ADCs work. They also act as reservoirs of chemotherapy. So if you think of the average chemo, it has an half-life of a few hours. You inject the chemo, it circulates in the body everywhere, but in 5 to 6 hours to 7, depending on the chemo, it's mostly excreted. But once you link it to a monoclonal antibody, it keeps circulating for days. The half-life of monoclonal antibodies is several days, and once you link chemotherapy, that chemo slowly detaches, and so you achieve not only a targeted chemotherapy that reaches the tumor cell, but also a prolonged infusion of chemotherapy. And we know that that can be important, and this mechanism of action made chemotherapies that were not so effective, like for instance, irinotecan. We don't typically use it in breast cancer, but irinotecan is the cousin of DXD or SN38 that are linked to ADCs and that work so well. So ADCs are complex, but if if we want to make it simple, they act in two key ways. They selectively, let's say, veiculate chemotherapy towards tumor cells, and they also act as reservoirs, which allow chemotherapy to have a prolonged, let's say, half-life in the circulation.
So I need to have a target to have an ADC, and I need to have chemotherapy. And obviously, I presume you will use the chemotherapy that you know might be active against that particular tumor or that particular cancer with the target. Tell me about the bridge a little bit. What is that bridge, and does it matter? Like what's the bridge? What's that linker, and how important is the type of linker that you use?
So yeah, that's very fascinating because the linker often gets little recognition, but actually the improvement of the linker may be what made T-DXd so effective and novel ADC so effective. So the first ADC ever approved for solid tumors was TDM1. And TDM1 had a non-cleavable linker, meaning a linker that required internalization in the tumor cell, degradation in the lysosomes before the chemo could be released into a tumor cell. And this is smart because it kind of makes the ADC tumor selective, but at the same time, it really restricts the activation of the chemo to some tumor cells that overexpress a target. Most of the novel ADCs have what we call cleavable linker, meaning a linker that can be degraded by different mechanisms. For instance, TDXd's linker can be degraded by catepsins, which are enriched in the tumor microenvironment. Other ADCs like sacituzumab govitecan or sacituzumab tirumotecan have acidic label linkers. So in conditions of low pH, the chemo releases. And this makes the chemo release more rapidly, more effectively, and this causes more activity, but also some side effects related to the premature release of the chemo. And so the idea is that with ADCs, you want to find that right spot in terms of linker stability so that the chemo is released in the right place in the body and not too much chemo is released in the circulation and elsewhere. And this really is a huge challenge, but also a fascinating one because when you get it right, the ADC really works well.
That's amazing. So I'm trying to think through this. So essentially, well, let me back up a little bit. I was listening to a talk a couple of months ago, and the speaker was talking about ADCs, and the speaker mentioned that there are currently today over 800 ADCs in development on clinical trials. Okay, I find this number staggering. I mean, are we moving to a point where we don't need chemotherapy? Because if we have something that's going to make chemotherapy better, why don't I just use ADCs all the time if I have a target and just put the chemotherapy link to it?
It's a good question. I think it's a matter of semantics because ADCs, in my view, are chemotherapy.
Right.
But a chemotherapy that works better. It's a new way of
Super chemotherapy.
Exactly. And so it's like when you think of fluorouracil, when we started injecting it with a prolonged release, that was still chemotherapy, but given a different way. And I think ADCs are chemotherapy, but given in a different, more effective way. And if you ask me 10 years from now, if many ADCs will replace traditional chemotherapy, I definitely say yes. At the same time, traditional chemotherapy, I think, has a broader effect irrespective of the target, and in some cases that may still be valuable. For tumors that are very heterogeneous, that are very advanced, and you have cells that have different genetic aberrations that have spread in different parts of the body, you may want something that has a broader activity. And so I don't think we're gonna completely forget about taxanes, about platinum compounds, etc. But I do think some chemotherapies will be replaced by better chemotherapies, by ADCs, especially because we have some payloads that really are from the same class of old chemotherapies. And so, for instance, all of these new ADCs, many of them have got topoisomerase 1 inhibitors as payloads. And they all seem to work better than irinotecan. So there's a chance irinotecan may be replaced by these ADCs. Even in gastric cancer, there is a randomized trial that compared T-DXd to mostly irinotecan. And T-DXd was much better, improved overall survival. So I think several chemotherapies will be replaced by ADCs, but some of them may remain, either because they have this broader activity or because we were not able to link them to antibodies, because there are still some chemos we have not yet linked to antibodies.
That was actually that was my question. So not every chemotherapy could be linked.
So it's a good question, which I've asked several times to a dear Italian friend of mine. There is a chemist specialized in ADCs called Raffaele Colombo, who's telling me that actually anything could be potentially linked to an antibody. The thing is that not everything is ideal to be linked to an antibody. Some some chemotherapies have the right potency to be linked to antibodies and work better as payloads. And right now, the main payloads we have are topoisomerase inhibitors, are microtubule inhibitors, such as MMA, the most common payload for ADCs, but also alkylators. And actually, the first ADC which you worked on, gemtuzumab osigomycin, had an alkylator, which kind of worked pretty well for leukemia and less for solid tumors. But right now, we have these three main classes. I do think we need to expand the classes of payloads we link to antibodies, but for the moment, we're kind of restricted to these three categories.
Yes, it's interesting. Before we went on the air, I was telling Paolo that, I've worked on gemtuzumab osigomycin, which is clearly the first ADCs but at the time, I really didn't think of it as ADCs. I was just thinking this is targeted therapy. It's an anti-CD33 against AML linked to calicheamicin, and I didn't think of it as an ADC per se, although it's in the class, because it's a targeted delivery of chemotherapy. So where are ADCs being studied in all kind of cancers at this point?
Definitely. I think, there's so much excitement, and it kind of started this excitement around 2018, 2019 with all of this wave of topo 1 ADCs, and now it's spreading rapidly. And the unmet need is just so high. So there's so many solid tumors, but also hematologic cancer that we treat with chemotherapy with poor outcomes, with PFS of a few months. We can definitely do better than that. But then the biggest challenge that is actually happening is moving these ADCs not to pretreated metastatic cancers, but to the early stage setting. And this last year, actually, at ESMO and ASCO, we saw the first data with TDXD in early stage HER2-positive breast cancer. Tremendous data. Destiny 5 and 11, two trials that showed that you can not only treat, but cure HER2-positive breast cancer with an ADC. And I think this is gonna happen across tumor types. Some of them still already have some mature data. Gastric cancer, as I mentioned, but also ADCs are approved for lung cancer, ovarian cancer, cervical cancer. TDXD has got an agnostic approval. You just need to demonstrate there is HER2 overexpressed and you can use it. And I think this will expand for sure across solid tumors. Some of them may be more suitable just because they're more sensitive to the payloads. Some of them, just as it happens in oncology, will be harder to treat. But for those, I think something that will help is fancy payloads. So these are an entire new category of payloads. We started from linking chemotherapies to antibodies, but now we're moving forward towards linking immunotherapies or things that can synergize with immunotherapy to antibodies, or linking radioisotopes, or linking protein degraders. So the idea of delivering something to the tumor is expanding across other molecules, and I think it's so fascinating.
Interesting. So we don't what we are linking does not necessarily have to be chemotherapy. It could be you can link an IO to the linker and deliver IO.
Absolutely. And there is the main class of IO that has been linked to antibodies is Toll-like receptor agonist, with the idea to ignite anti-cancer immune response and synergize with immune checkpoint inhibitors. But there is just so much more. For instance, just an idea, in breast cancer, we have some targeted therapies which work well but have relevant side effects. For instance, alpelisib, which is a PI3K inhibitor, very effective, but it has a lot of hyperglycemia, stomatitis, rash. I wonder if you link something like that to an antibody and you increase the concentration in the tumor cells and avoid the healthy cells as much as possible, maybe you can retain the efficacy and avoid the side effects. So the idea is linking potentially anything to antibodies to deliver it to the cancer cells. And it sounds easy in theory. It's much harder in practice. There's not so many molecules that have really worked out so well as payloads, but there's just so much interest and there's so much investments as well that I think many of these fancy ADCs will actually come to the clinic and succeed. And finally, one thing I kind of love, it's very novel, is dual or multi-payload ADCs, linking more agents within the same ADC. Instead of just linking one agent, one chemo, you can link a chemo and some targeted therapy that synergizes with that chemo. And some of them entered phase 1 testing last year, actually.
Amazing. So what area on the ADC armamentarium are you focusing on research-wise? Is it just mainly clinical in breast cancer or so on, or are you researching other aspects of ADC development or drug development or things of that nature? Or you personally?
I would say I'm a breast oncologist, and so everything for me starts from breast cancer. But in truth, what starts somewhere often ends up somewhere else. And so I'm finding that whatever I research kind of resonates and is amplified in other diseases and then comes back in some form of some new ideas that can help me to advance breast oncology. My current major task is actually to make ADCs more precise through biomarkers, because the original idea was kind of simple. Was, you just stain a slide of the cancer with immunohistochemistry, you see if the target is there and if what is the intensity of the target. If there is the target and is intensively expressed, then you're gonna have a response. This completely failed, this paradigm. We realized that immunohistochemistry for targets is not a good predictor of ADC efficacy, just because ADCs are more than just selective delivery systems. They're more complex in the way they work. And so one thing I'm doing is trying to obtain as much tissue from patients that receive ADCs and trying to predict which patients respond and try to understand why they did not respond if they did not. And to do this, I'm partnering with folks around the globe. So whenever I see a promising technology or assay, I try to collaborate in order to understand if it can help to predict which patients benefit from ADCs, which is going to be specifically relevant when we use them to cure patients. You really want to know, after you remove the tumor, which one is the right ADC to use to get rid of any stray cells in the body. And that's my major task right now.
I have to tell you, this is almost like this is the holy grail. And I don't know if I don't think it's just for ADCs. I think it's really about can we figure out who to treat and not to treat predictively? Can we predict who even needs therapy? I think in breast cancer, at least, and I'm not a breast medical oncologist, but Oncotype DX is the closest I can think about, where it's really something used at scale, where you could tell a woman at least, look, you probably can safely avoid the use of chemotherapy. I'm pretty sure you could improve on that, and I will be wonderful to get to a point like you have the Oncotype DX kind of thing for ADCs, right? I mean, that's what you're thinking about.
Exactly. I love this idea. And in truth, what I'm kind of envisioning, and for the moment it's a vision, which I'm trying to translate into reality, is kind of an Oncotype DX of ADCs, where you not only look at the target on the tumor cell, but you also look at the overall immunity of the tumor. You look at internalization markers. There are some proteins that predict if the ADC will be internalized or not. You look also at the catepsins, because you need kind of these molecular scissors that cut the linker, and you want to know if they're abundant or not. And when you put all of this together, maybe you're able to predict better which patients benefit from ADCs and use only the amount of ADC you need. And so, for instance, one thing where I've been working on at Dana-Farber is a trial called Attempt, where the idea was replacing chemotherapy with a well-tolerated ADC. Randomized trial, half of the patients, some patients actually got taxanes, some patients got TDM1, and the patients got TDM1 actually had much less alopecia, had much better quality of life, and also seemed to have better outcomes. And so if we cannot fully get rid of chemo for some patients, at least we can try to make that chemo better tolerated. And also we tried to do translational analysis of that trial, and we did find some predictors of the efficacy of TDM1, that specific trial. So that's the idea. It's gonna take some work, but the good thing is that there's a lot of people interested at working, partnering, and so it's been very rewarding over the past few years.
Paulo, are there specific adverse events or toxicities that are just unique to ADCs that are just different, for folks who are using ADCs in the community, the general medical oncologists or folks that may not be as well experienced with ADCs as you are? Or are the side effects as whatever the chemotherapy that you are really, the payload that you're using? Like, can you help us understand the uniqueness of adverse events or side effects with this class of drugs?
So that's a great question, because the truth is that both are real, both are true. ADC, the main side effects of ADCs are chemotherapy related. And so you may expect to see neutropenia, fatigue, nausea. And so it's important to know that even if you're administering kind of a targeted agent, it will still come with some chemo related side effects. It's not the same for all ADCs, but you often see side effects such as nausea, which require prophylaxis, or fatigue, which may require dose reduction, peripheral neuropathy if you're using a microtubule inhibitor ADC. But then you have the other side, the target related toxicities. So it's important to remember, if you're using an anti-HER2 ADC, you should expect some degree of cardiotoxicity, because HER2 can be expressed in the heart. But also if you use a TROP2 ADC, TROP2 is highly overexpressed on mucosal membranes and on the skin, and you may have rash and mucositis, which is important to know and try to mitigate as much as possible. And this is true for every ADC. And then there is this peculiar side effect that has emerged with some ADCs, that is interstitial lung disease or pneumonitis. And in truth, it's not too common, but there's been fatal ILDs in clinical trials, which is why one thing to remember with some ADC, like T-DXd, Dato-DXd, is to monitor patients closely with CT scans of the chest. And so what I would say to anybody using ADCs is to remember that these are chemotherapies, but they also come with some new side effects, and each ADC have got different unique side effects related either to the target or to the entire structure. Right now we think of ILD as related to the entire structure of the ADC, and we're trying to learn more, but it's a very tricky side effect.
Are there any other things on ADCs that I should have asked you that I did not, that people should be aware of? Because I do have one separate question that is related, but not really related specifically to ADCs.
Well, I do think you did a great job at digging through the relevant stuff regarding ADCs. One thing probably that is just very practical is how often are ADCs administered. And one interesting thing is that most ADCs are given once every 3 weeks, just because they are monoclonal antibodies and they can last for long in the body. They have a long PK, but not all of them. Some of them are given more frequently, like sacituzumab govitecan or enfortumab vedotin. And so that's another important thing to figure out. And then one thing that I didn't mention regarding the toxicities, or I just allowed to, is the prophylaxis. Each ADC have got different prophylaxis strategies, and so it's important to remember if you use sacituzumab govitecan, patients may benefit from prophylactic growth factors. If you use darapotamab deruxtecan, you may want to remember to use mouthwash and also to make sure to use drops for avoiding keratitis. And each ADC has got some different prophylaxis to remember.
Interesting. So my other question that you alluded to earlier, and I feel it's really important about the HER2 low and because we were, at least I was trained back in the day that the Herceptin and all of these it has to be the HER2 expression +3, all of these things that we were trained. What happened? Like do you have the history of when did we actually start realizing that this may not be as important and there are classes of drugs that actually work in HER2 low and what that means?
2018. In 2018, everything kind of changed. And then the big change happened in 2022. So in 2018, there were the first data from the phase 1 trial of T-DXd and another ADC, trastuzumab deoxycarmazine, where the investigators not only enrolled patients with HER2 positive breast cancer, but also this new category of HER2 low, which means HER2 negative with some HER2. And that's where, when you look at the waterfall plots, your jaw drops and you're like, how is it possible that you have 40% response rate with an anti-HER2 agent in HER2 negative breast cancer? That was the moment in 2018 when I saw those data and I started thinking like, this is weird, this is unexpected, let's try to figure out why that is. And which is why I committed my next few years after 2018 to understand this. And then 2022, there was the first phase 3 trial that tested T-DXd versus chemo in HER2 low metastatic breast cancer. Destiny Breast 04 plenary session at ASCO, standing ovation. It was really impressive. I remember crying when I saw those data because you had an improvement in overall survival with an anti-HER2 agent in a disease where we didn't think that anti-HER2 agents could work, HER2 low, and in a disease that's very prevalent, because when you think of HER2 positive breast cancer, gastric cancer, colorectal cancer, you're talking of a small subset. In breast cancer is 15%, in gastric cancer I believe 20%, colorectal cancer 5 to 10%. But when you talk of HER2 low, that means half of all patients with breast cancer. That means a much larger percentage of patients with any cancer. And so that moment, 2022, the standing ovation at ASCO, suddenly meant that we could expand ADCs to a much larger population of patients if you can just have even low expression of the target. And that was kind of huge.
Amazing. And pathologists out there are reporting this now, like when you see pathology reports coming from elsewhere, are the pathologists able to report this accurately to guide the clinicians what to do?
So yeah, that's an interesting question, because actually there was a huge controversy regarding this HER2 low, because suddenly, like before that moment, we just needed to dissect to recognize HER2 positives from HER2 negatives. And it took 20 years to fine tune the ASCO-CAP guidelines to do that. And we were at a point where we were pretty good pathologists. We were pretty good at recognizing HER2 positive from HER2 negative. And suddenly the threshold shifted from HER2 positive to low to HER2 low compared to HER2 zero. And HER2 zero, everybody suddenly realized, didn't even mean absence of HER2. HER2 zero, if you look at the ASCO-CAP guidelines, it says absence of HER2 or some mild expression over HER2. So it suddenly was very confused. And that's when research started in order to try to refine that. And I think one interesting aspect of all of this is computational pathology that suddenly was showing able to distinguish the different HER2 categories better than the human eye. And this is, of course, a huge topic, AI, computational pathology, that could refine the way we treat cancer. I think this application of distinguishing HER2 is one of the very promising ones. But going back to the present, right now, yes, our pathologists are tasked with distinguishing zero from low. And the thing is that you can decide to be generous or not, because there is kind of some subjectivity there. And so there are cases where you call your friend pathologist and you're like, hey, are you sure that you cannot see any HER2 there? And
How sure are you? How sure are you?
because it makes a difference for the patients. And so we are right now in this kind of confused area of HER2 zero, low, ultra low. It's very confused, but we're trying to do our best to identify the patients that can benefit from TDXT and ADCs and the ones that cannot. And possibly computational pathology will help in the future.
Well, Paolo, congratulations on everything you're doing, really. I think my listeners and viewers are, on behalf of them, very grateful to all the work you're doing and to making what I believe is a complex topic very easily digestible and understandable for all of us. So I appreciate you coming on the show, really. Thank you so much.
I am so grateful about this. Thank you, Shadi.
Okay, folks, thank you so much for joining. Thank you, Paolo, for coming on the show. I really, really, really appreciate you coming on and being on this show. Thank you for everything you're doing, and I can't wait to see everything that you are going to be doing moving forward, research, media, and everything else. So congrats on all of your success. Folks, check out my podcast on all of the platforms, rate it, share it with others, and let me know what you think. Propose guest topics. My door is always open to you all. Before I let you go, I'm going to leave you with a saying by Winston Churchill. We make a living by what we get, but we make a life by what we give. Until next time, take care.